an hour and a half. First, we'll hear about how colleagues listen to or track rumors in different contexts, with refugees living in camps in Uganda and with LGBTQI+ migrants in south of Colombia. We will also learn from past experience with different vaccines introduction and rollout to promote vaccine equity and to address concerns of this population in relation to vaccination. We'll follow with a discussion among the panel and participants, and we've allocated a generous amount of time for questions and discussions from the audience. So please do share your questions in the chat and raise your hand if you have something to share. So thank you again to everyone who have joined us from everywhere you are on the planet. We have people from, from Asia to Latin America. Very pleased to have you all. Today in the panel, we have Mbeiza, who is the Accountability to Affected Person Deputy Coordinator at ULEARN in Uganda. Giovanni Molinares, Human Mobility Coordinator at Caribe Afirmativo in Colombia. Genevieve Hutchinson, Senior Health Advisor at BBC Media Action, talking from the UK. And as moderator, we have Katherine Harris and Nori Nafki, both colleagues of the RCC sub-working group for refugees, IDPs, and migrants and host communities. Before I hand over to the panelists, let me start with a short introduction on some major challenges Internews think risk communicators can face when communicating on vaccine in refugee, IDP, and migrant context. We know that throughout history, infectious disease have been associated with the othering. And in many humanitarian contexts, the challenge of distributing a vaccine has added the complexity of competing vulnerabilities of citizens, migrants, and refugees, a patchwork of vulnerability that relates to legal status, birthright, and stigma. The difficulty of working with prioritization, stigma towards these groups, and where the public perceive they should be in queue cannot be ignored. As vaccination plans are developed and being implemented, the UNHCR is tracking which of these plans include refugees in their national plan and advocates for inclusion. One example is Lebanon, home of refugee population per capita, the largest in the world at the moment, as well as 300,000 migrant workers. Refugee groups have been included in national vaccination planning, and the UNHCR and the United Nations Relief Works Agencies for Palestinian Refugees, UNRWA, sit on the National Coordinating Committee for Vaccines. For refugee and migrants group, therefore will receive COVID-19 vaccine in tandem with other vulnerable Lebanese citizens. But despite this planning, rumors continue to evolve about when and if refugee and migrant groups will have access. As an example of rumor, Internews has seen in our works on rumors around COVID, one on Twitter says, the United Nations must complete the vaccination delivery for all the Lebanese before giving it to any stranger. While on the other hand, we also saw that fears swirl within Lebanon about the vaccine being tested on marginalized communities. One example on this is a post on Facebook that said they have sent the vaccine to the Middle East so they could test it and continue their trial. So whether refugee groups are or are not included in national vaccination plans is bound to create backlash. Internews has seen this already in data collected in Lebanon and Colombia. Giovanni will explain a bit more on Colombia later. These decisions on rollout prioritization ultimately impact on how we communicate about vaccine in each context and the impact of that communication on trust relationships. If refugees and migrant groups are prioritized, you run the risk of a backlash from citizens over preferential treatments. If these groups are second in queue, you risk further stigma and prejudice, as they may be viewed as unprotected spreaders of the virus. The us versus them mentality is natural when the vaccine is viewed as an article of scarcity and people are desperate for their life to return to some kind of normal. We're all in that boat at the moment. Therefore, combating this stigma should be the focus of our communication efforts. We may need to communicate differently to refugees and migrant groups and with the host population, use different channels, and address the key concerns on either side. We should encourage host community to see the vaccination of these groups as part of the global solution to COVID-19 and not see them, the migrants or refugees, as homogeneous. Just as in the host community, there are vulnerable groups within refugee and migrant communities that may need prioritization in front of other groups. For refugee and migrants, you may also face issues of trust. Many may be unwilling to attend government clinics as part of national campaigns, especially if they have been previously undocumented or unregistered. And therefore, humanitarian groups may need to play a role in the distribution of vaccine. Definitely, the Red Cross movement is taking part of this effort at the moment. Now, I will hand it over to Mbeiza from ULearn, who will talk to us about the interagency rumor tracking work in Uganda refugee camps. So over to you, Anne.
Thank you so much, Julie. So I'll be talking about the interagency COVID-19 rumor tracker in Uganda. And this is the ULearn website that you can always go to get more information about what we do, including the rumor tracker. Next slide, please. Yeah, under the methodology, the rumor tracker is considered a prerequisite to building trust, engaging in unstructured conversations, and also listening to be able to identify rumors. Now, this methodology builds on a two-way relationship where data collectors or community volunteers do not only register feedback, but they also provide information which gives communities an opportunity to access relevant and trusted information. Now, in this, rumor collectors are community volunteers or incentive workers or even staff who are trusted in communities and engage directly with communities already. So then identified rumors must be submitted in the interagency Kobo toolbox or on a paper version as an alternate where there are no, where we don't have the tabs. And this must then be collected and registered into the Kobo server biannually. Next slide, please. Okay. Oh, yeah. So what makes Uganda's implementation unique? Data collection is carried out through a range of approaches, but is broadly collected reactively as staff, partners, or even volunteers interact with refugees directly. For example, collecting and submitting rumors identified during phone calls to the FRRM or during face-to-face conversations, and they submit these rumors through Kobo Collect. Now, maybe a little about the Kobo Collect. It's an Android-based application used to collect data, which feeds into a Kobo toolbox account, and this is managed centrally. So it's further, it is an interagency initiative that involves collecting and analyzing data on rumors and misinformation about COVID-19. And okay, one thing about this is it's including but not limited to misinformation about causes, origins, cure, risks, preventive measures, and vaccines. I'll explain this in another slide a little further. So the data is analyzed jointly through a dashboard that is updated on a bi-weekly basis. So then the dashboard informs the monthly rumor bulletin, which is a high-level one-pager that provides a summary of the details on a bi-monthly basis or twice a month. So all in all, its implementation is a cheap and scalable way of getting rumors in person. And it also means that we can track rumors and misinformation over time, anytime. Next slide, please. Now, why build connections between the tracker and implementation? Now, rumor tracking here informs programming. Normally, after categorizing and analyzing rumors, the team, together with stakeholders across settlements, design appropriate or the right messages to the community to achieve the desired behavior change. Now, at the initial stages of COVID outbreak, there were all sorts of messages, we remember, which were produced and disseminated in communities. For example, there is this one that I've quoted, that is men. There was information going around settlements that do not touch men, but then this wasn't well explained to the community. They were interpreting it like women should not touch men, they should not go close to men. And yet this was just an acronym to mean, do not touch your mouth, your ears, your eyes rather, and your nose as a preventive measure to COVID. So then it was misinterpreted as men, and at the end of the day, there was more of domestic violence in settlements because women were shunning their men. So how did this inform programming? We analyzed it and really saw the need to go out there with the right information that men is actually an acronym, meaning do not touch your mouth, your eyes, and your nose. So then programming, yeah, that led to awareness creation within the settlement. And then in relation to that, FAQs, or frequently asked questions or fact sheets, are normally based on collected rumors that are analyzed through the system. And these are updated according to the rumor trend. Initially, during the COVID outbreak, at the initial stages, there are SOPs that we're talking about prevention. But then over time, we have vaccines-related FAQs. And these are developed by the Ministry of Health these counter rumors and misinformation in communities that range from general information about COVID-19 and COVID-19 vaccines, such as how do the COVID-19 vaccines work? What are the different and difficult COVID vaccines within the country? And then how about the availability? And then questions around vaccine eligibility and priority groups. There are further questions around vaccine availability and administration, vaccine safety and effectiveness, to common side effects and risks for serious reactions. Now, this also promotes, connections promote integrated programming, such as use of established projects already and staff. Also, you find that rumors are countered through already existing channels. We have community structures such as the village health teams, the refugee-led organizations, radio broadcasts. And then we also have coordination platforms such as meetings that are already within settlements. So we use that as ways or platforms to talk about the right information on COVID-19 and vaccines. So typically, rumor collection is integrated into existing tasks rather than standalone activity. And this is for cost and time efficiency. So for example, if rumor collectors are already engaging with community members, like in protection monitoring, food distribution, routine home visits, or even other data collection activities, they may just add on some conversations or questions related to ongoing rumors in the community. In other words, the volunteers are always prepared to record rumors anytime and from anywhere. So, and then we have, I will mention the role of the AAP regional staff. These support with categorization of these rumors and supporting partner organizations to use the COBO tool. Besides, these staff continue to lead on the analysis of rumors with stakeholders, like I mentioned earlier, and they share summary documents that inform the high-level bulletin that provides a summary of the dashboard on a quarterly basis. Now, note that sometimes information that is tagged as NA within the dashboard are pointers to gaps. Not applicable in the dashboard are pointers to gaps in service delivery in different sectors. So the team then refers such cases to individual concerned agencies or partners who then have to address them. So it's not only about the rumor collection, but also we do referrals in line with service delivery gaps. So then the other one is strengthening risk communication and community engagement efforts by increasing awareness about COVID-19 SOPs and vaccines. So this initiative provides valuable insight into how information about COVID-19 and the vaccine is understood and what information gaps exist to improve the communication effort with communities. Persons of concern or the clients are central in rumor tracking. We directly involve those affected people or the clients in understanding the risks that they face. We involve them in response actions that are acceptable, such as adhering to SOPs, Ministry of Health standardized messages and precautions, and ensuring their meaningful participation this way and contributions towards making decisions that affect their lives. Now that way, we further contribute to building trust with the people we serve, ensuring their protection, and also this helps us to manage risks, making our programs more relevant, more appropriate, and making us really more accountable to the people that we serve. Next slide, please. Now, these are some of the common vaccine rumors that we have in the dashboard. So for vaccine categories, they are grouped in three, where we have the bioweapon related rumors, the negative side effects, and ineffective. So some of the examples that fall under bioweapon, for example, is that now this is direct speech that we picked from the dashboard. The COVID-19 vaccine is meant to kill people, especially Africans, to reduce their population. Then in relation to negative side effects, they say when injected with the vaccine, your blood clots and you die. The other one is when you are vaccinated, you run mad. Then under ineffectiveness, COVID-19 vaccines are not effective. Communities are not sure of clinical trials. So I just filtered a few rumors to share with you. And then on basic statistics, now rumor collection is done across 13 refugee settlements in Uganda currently. And then we have over 25 agencies that are actively participating in rumor collection through the structures. There are structures established on the ground. And this is inclusive of the refugee-led organizations. By the time I made this slide, that was about a week ago, I'm sure by now the rumors have increased. So by then we had a total of 2,756 rumors then that are collectively categorized under downplay, vaccines, upplay, origins, transmission, prevention, those related to cure, related to partner or government responses, for example, repatriation or reduction in food rations. Symptoms, there are those who say it's like flu, others say it's just a symptom of flu, COVID is not serious. There are those that are ambiguous. So those are some of the categories besides the NA that we have in the dashboard. So I will just drop a link for the rumor dashboard so that you can go in anytime and check the rumors for yourselves. Thank you. And I hand over to Giovanni.
Thank you very much. As Julie said in the beginning, my name is Giovanni Molinares. I'm Immigration and Refugee Project Coordinator at Caribe Afirmativo. Caribe Afirmativo is an NGO located in Barranquilla, Colombia. We have been working for the defense of LGBTIQ+ persons' rights in Colombia since 2006. 3 years ago, we started working with LGBTI, refugee, and immigrants communities. Caribe Afirmativo works in collaboration with Internews on social media rumor tracking. One of the main findings of the social media mapping, we found that LGBTQI+ migrants had a lack of access to relevant information on social media. This increased the fears in this community, fear to seek for healthcare services, fear to identify their aggressors, fear to show their gender identity, express themselves as LGBTQI+ persons, fear to be an immigrant or refugee. Next slide, this. A stigma towards migrants groups has featured consistently as one of the top-ranking themes of rumors surrounding COVID-19 in our rumor data collected in Nariño, in southern Colombia, in the in the border with Ecuador. Rumors highlight fears that the migrants are the source of the outbreak, or that if they are included in national vaccination plans, there will not be enough doses for Colombian citizens. But migrants are also not immune to rumors surrounding the vaccination campaigns. Perspective collected from migrant communities online and in person reflects concerns about who will access the different vaccines available. For example, vaccination comes in a stage that means that at the first, the high class and the vaccine will be different for the lower class, more exactly like the Russian or the Chinese vaccine. In that case, it's screwy because we, the poor people, will have the worth of the vaccine, will have a different composition. That was information taken from Facebook. Rumors, commentaries, and discourse promoting discrimination and stigma are not new in this pandemic. In Colombia, the lack of credible data on migrants' infection rates has resulted in the widespread perception that the migrants community is somehow immune to the virus, well before any perspective on vaccine rollout plans. One of the most violent comments here in Nariño mentioned that the virus could be cured by injecting the blood of Venezuelans. In face-to-face conversations on focus group discussions, Venezuelan migrants expressed that these rumors caused them to feel isolated and ostracized, and decreased the likelihood that they will seek out medical services for fear of being deported or receiving inadequate care due to discrimination. Currently, Venezuelan migrants expressed that these new forms of xenophobic commentaries, especially those that endorse unequal access to the vaccine, have led the Venezuelan population in Nariño to hide, to become anonymous, or to avoid social media even more, making it even harder for them to access relevant, credible information. Additionally, the LGBTIQ+ migrant population has been particularly affected by rumors suggesting that the vaccine will turn citizens into homosexuals. This and the fact that Nariño has become one of the most violent departments of this community has contributed to isolate the community even further. Next slide, please. Where LGBTQ migrants look for information, that's like a big question for us. Most migrants use Facebook because they can access it for free through cheap data packages. They use open groups to communicate about migrant issues. Facebook has like agreement with mobile provided in Colombia for free use. But we found there were no groups on Facebook that were safe for LGBTQI+ people. So they use YouTube to find information relevant to them. These YouTubers often were in Nariño. They could be more global or regional, but they trusted this information and felt a connection. But it couldn't tell them where it was safe to access healthcare locally, for example, for LGBTIQ persons. So we decided to start like WhatsApp groups. These were private groups with LGBTIQ+ migrants and refugee persons, where they could interact between each other safely. This group had more than 50 people at the end of the project in them, and we shared 3 types of information. They were like really sick of COVID information. So we talk about rumors and misinformation about COVID in Nariño and the vaccines, and also we share like live information about celebrities, news, so they will enjoy being in the group. As well, we hosted more than 20 events, virtual events, with these groups to answer more questions and connect them with medical professionals to show them respect. Next slide, please. So, for example, through these groups, we found out about Isaac. Isaac is a trans man from Venezuela. In December of 2020, Isaac was on his way to Chile through Ipiales, the Colombia border with Ecuador. Before he took to the bus to cross the border, 2 guys approached him, and when they found out he was transgender, they punched his face and pushed him off over a 6-foot cliff. Isaac spent 2 weeks without leaving his hotel room. He was afraid to look for help because he thought he had no rights, right to healthcare, right to be taken care of, right to the recovery process, the right to be an immigrant. Isaac was a member of our group and felt safe contacting us for help. We were able to connect him with safe services to help him recover. At this moment, Isaac still has not recovered the mobility on his legs and needs help to walk. What would happen if Isaac was not afraid to tell he is a transgender man who needed help? The social media mapping created by Internews allows us to be aware of the importance to listen to the most vulnerable groups in social media as well. I now hand over to Genevieve Hutchinson from BBC Media Action. Thanks.
Thank you very much, Giovanni. And hi, everyone. It's lovely to be here and to be part of this panel. For anyone who doesn't know us, BBC Media Action designs and delivers communication strategies, radio and TV programs, digital content and tools and training for media and non-media partners in Africa, Asia, the Middle East, Eastern Europe, as well as globally. We are part of and have been responding to COVID-19 and are now working on COVID-19 vaccines in a number of countries and at the global level. But today I wanted to talk a little bit about some of the learning from our past projects on immunization and vaccination, specifically around polio vaccination. And these are projects that we undertook for northern Nigeria, Afghanistan and Somalia, because I am, and we all are, I think, seeing quite a bit of overlap in some of the challenges that past vaccination programs have faced and what's going on now. Next slide, please. So before I go any further, I wanted to talk a little bit about some of the context from before. So we started having conversations about these projects in 2013 to 2015. They all had slightly different start times. And so some of the sort of issues that we were looking at then that I think still have relevance now are the very challenging context, particularly if we're thinking about migrants and refugees, the very challenging context that they are in and that they face, and that vaccination is often not the priority, or definitely not the priority for many people. There are far more immediate and tangible risks to life. And any programming around vaccination needs to be able to consider that and kind of work within that. There were also issues around illness and death was often not seen as being within somebody's control. There was quite a lot of fatalism. And so, you know, whether you get polio or not, whether your child gets polio or not, well, it's beyond your control. There's also very entrenched misunderstandings as well as disinformation about infectious diseases, about disease transmission, and then again, particularly around vaccination and vaccination campaigns. By the early 2000s, there were sort of entrenched beliefs around polio vaccination campaigns being about, and the polio vaccine sterilizing people and being a conspiracy theory to sterilize people. That was going around, you know, that was already entrenched by the early 2000s. So we're seeing repeats of some of these rumors, but just applied to a different vaccine or a different issue. There was a lot of in terms of lack of trust or belief in vaccines, again, lack of trust in the campaigns, in vaccinators, in the providers or the people who are perceived as developing the vaccines, and in government as well. Again, lots of misinformation about side effects and beliefs around side effects, and why a particular vaccine might be focused on and why it might be being pushed in particular communities as well. So where we've seen areas where polio has remained endemic, or you get repeated measles outbreaks, you get big vaccination campaigns, and then people question why. Also because, say, for example, with something like polio, a little bit like the coronavirus, it's not very visible, or the causes of something like disability or death as a result of polio might be contributed to another cause. There's also access issues, so based around service availability and vaccine availability, challenges of movement to be able to access health services or vaccination services, or for vaccinators to get to communities. And that might be related to geography, if we think about Somalia, Nigeria, and Afghanistan, as well as things like security. And then there's issues of gender. So norms around gender that mean that a woman may not be able to access services for herself or for her children, or make a decision without a man or husband being present. We also saw and continue to see threats and actual violence towards vaccinators and towards people who are being vaccinated, again, particularly linked to polio vaccination. And there were some cases when we were first starting the project in Nigeria, particularly, there were a few small cases. It wasn't something that was widespread, but where, particularly amongst IDPs coming out of the Northeast, they needed food, they needed shelter, and they felt that there was an emphasis on vaccination and not on meeting what they saw as their priority needs. So there were stories of people refusing vaccination as a sort of leverage, a kind of, if I get vaccinated, like if you give me this, then I will get vaccinated. And again, that's coming from a place of really being in need and not feeling that you've got any power to do anything else. That feels like that's the sort of one bargaining position that you have. And then, as now, we've also got huge issues in terms of the balance between prevention behaviours. So particularly with polio vaccination, there was concern around, if we focus too much on things like hand washing and sanitation, will people think that that's what they need to do and therefore not take up the vaccine? But then also you've then got the balance of people only taking up the vaccine and not, and then not necessarily following the prevention measures. So, looking at how we manage both. And then obviously when we're thinking about mass communication campaigns, you're looking at something that's needs to be local, regional, and sometimes national, but you're cutting across areas with incredibly diverse communities, long histories of different relationships between communities, potential tensions, lots of different languages, accents, dialects, belief systems, and so on. So we're having to manage, think about all of those. So in terms of our approach, each project we undertook a lot of research with communities. So again, speaking to what Anne and Giovanni have talked about, really listening to people, engaging with people, and with the communities themselves that where vaccination levels were low, as well as people who were taking vaccines and so trying to understand what helped them to get vaccinated. And then also with community leaders and with experts, so people who might be have been working with those communities and on these issues for long periods of times, and experts from different sectors. So we're not just looking at the health issue, we're looking at what individuals are going through and the context in which it's being experienced and what their other priorities are. And so we used, our approach is to use media and communication. So given what communication channels people were primarily engaging with, most of our work was around radio, but we did also do TV programs as well, did a bit of social media, and also when it was possible, in Nigeria we were doing community-based live recordings of our weekly radio drama. And we were combining long-running, so these are programs that were on. In Somalia, it was shorter because it was a response to an outbreak, so it went on for a year. In the other cases, these programs went on and were on every single week for years, and they were complemented by our own and then other organisations' campaigns. And the projects were funded by UNICEF, so UNICEF also had a lot of partners doing a lot of other work around the provision of vaccination, community mobilisation, and then media campaigns as well. So the projects, we did a lot of research at the end as well, and the projects did increase understanding and knowledge. They helped to counter and change some of people's beliefs from believing in some of the mis and disinformation to belief in some of the facts around vaccination and child health more broadly. And it did increase intention, and we had some reported increases in uptake as well. So reports from health workers as well as people themselves saying that they had been getting vaccinated. We also saw increases in discussions within families and communities. So where polio and vaccination wasn't an issue in many communities, we saw it increasing in the places where we were working. And then we also saw the increase of the perception of polio and other vaccine preventable diseases as a risk that could be prevented with vaccination. Next slide, please. So super quickly. So when you're thinking about how are you going to be addressing vaccination and COVID-19 vaccination, what I'd ask you to think about is how are your strategies and your activities supporting engagement and partnership across communities and sectors? And again, Giovanni and Anne and Julie have already talked about some of this engagement and partnerships. They've also already talked about, are we listening and learning from the people that we want to engage with and understanding everything, not solely looking at the public health issue that we might be interested in? And are we using media and communication to do more? And are our activities relatable? And are we asking people to do something that is actually seems doable to them? Next slide, please. So I'm going to focus just on the media and communication because Julian, Anne and Giovanni have talked a little bit more about engaging and listening and also talking about media a bit more. But I think some of the key points that I wanted to make were that we've seen over the past year a lot of campaigns and a lot of messaging, and we need to do more. We need to be able to use media and communication approaches to really engage with people and to give people opportunities to talk and ask questions and get really direct answers. And that's one of the things that can help mitigate mis and disinformation kind of before it starts. Understanding of how the body works, of how infectious diseases are transmitted is often very low, and we can sometimes forget that. So giving people a chance to ask questions and ask questions from people they trust, being able to bring together. So in our project in Nigeria, in these live community recordings, which we also did non-live and studio-based, and you can do them through studios, through call-ins, through a variety of different ways during this pandemic, so they can be adapted. But one of the things we were doing was live recordings, and so you'd bring the community together, and we'd have women's only groups, we would have community leader only groups, and then we'd have broader community discussions. So creating safe places for people to be able to ask questions. And we'd do the recording, and then we'd have community mobilizers and experts from UNICEF to help facilitate and respond to questions. So drawing out a lot of the fears and concerns around things like side effects, around uptake. And we try and hold these recordings on the same day or the day before, a couple of days before a vaccination campaign, so that people had a chance to kind of process what they've been thinking about and learning. But then if there was that increase in intention, it was then really easy to go and get vaccinated. And that point about people being able to ask a question in the way that they want to is really, really key. In Afghanistan, it was a radio magazine program, and we worked with UNICEF to calculate when the different vaccination campaigns would be and time specific content on the radio program, so that it happened before a vaccination campaign, so that people knew what would be happening during a campaign, when it might be happening, or when they could expect it. But being very cautious about safety and about risks for vaccination campaigns, so not giving specifics when we're talking about it. All of our programming also used a lot of creativity. So we used a lot of drama, a lot of stories to be able to role model kind of some more sensitive issues, to be able to explore some of the norms that might be stopping people from getting vaccinated, and to be able to really emotionally engage with people. So people are getting engaged with hearing people who are like them. So this idea of being relatable. Hearing people like them, listening to and following their decisions and their own journeys of change, the consequences of different decisions and actions, and building the skills to be able to talk with health workers and the confidence to talk with health workers and ask questions of vaccinators. And at the same time, one of the things we found with our project in Somalia was health workers listening to the program and it helping them to be able to talk kind of more clearly when they were doing house-to-house visits as well. And they said it really helped to build trust. That's a whistle-stop tour. I've gone over time a little bit, so I will stop there. And any questions, please do put them in the chat. Thank you very much.
Hi, thank you so much, Anne, Giovanni, and Genevieve. They were really great presentations for everyone. I'm Katherine. I work with UNHCR and I co-chair the RCCE sub-working group for refugees, IDPs, migrants, and host communities, particularly vulnerable to the pandemic, with IOM and UNICEF. I think we have probably some questions from the registration, so I think better I don't talk or I don't do a recap. I think the presentations are all really clear, identified some really strong points, and I think what I'm taking away very much is the need for community engagement and for listening and feeding back on what we hear. There's one question straight away in the chat, and I do encourage everyone to either put your hand up or put questions into the chat box. Collins Chimuti, is that right? You've asked, is there a specific system that has been developed to help in tracking COVID-19 rumors and misinformation? Do any of the panelists want to answer that question? My understanding is there's not a global one, but I know that different organizations have developed different ones. Does anyone want to jump in?
Can I come in here, Katherine?
Please, Noreen. Yeah, jump in.
Yeah, thank you. This is really an important question. Just to let everyone know, and I will definitely also share more information related to that. So there is a social listening component that UNICEF is heavily investing in now. In ISAR, in West Africa, Eastern African region, Middle Eastern region, and also in European region, we have set up a system of social listening. So that social listening is basically rumors tracking and monitoring. So we are getting a lot of information about people's questions and concerns related to vaccination, related to the access and so on. And that is giving us actually more idea, and on the basis of that, the organization is willing to invest even more into this because this is becoming the key challenge these days. So yes, so that's the system that we are using right now. I can share some of the, let's say, the weekly updates that I get from different regions. You can see how different countries are. They are like doing the data analysis and visualization, and they are circulating so the countries know what are the concerns of people in those countries. Over. I don't want to take up more time. Over to you, Katherine.
Thanks so much, Noreen. And I just want to also really say that if anyone has something to share, a best practice, or they have an answer to a question, please do put your hand up. We can unmute and you have the chance to speak. It really would encourage dialogue from participants as well. As most of you probably aware, when registration happened, we asked for some questions. We've tried to look at them. We might not have time to address all of them because I'm also hoping people will put some more questions in the chat as well. But the first question we have is, are you aware of any specific rumors or misinformation affecting refugees more than the local community? And if I'm right, Julie, you had an answer to this one, is that right?
Yeah, it was a bit in my presentation, and yeah, from what we saw, I mean, Internews, we had it's currently on hold, but a COVID rumor tracking project running in 7 countries simultaneously, and it was all in humanitarian context and always either with displaced communities or refugees. And what we saw is a bit what I was one of the point in my presentation. It's it's on both sides. It's either people are scared, can be scared that the refugees or the migrants can bring COVID to them. We saw it even now in Sudan with the Tigray crisis and the influx of refugees from Tigray. At the very beginning, that was the main thing. There's no screening at the border. We will get just flooded with COVID cases in the country. So, you know, this is one fear, and the other one is, well, refugees are receiving too much support and aid compared to the population who also needs support and aid. So some kind of jealousy and people feeling that refugees are better treated than the citizens of the country. So a bit like hateful speech around that. So it can go on both sides. If the refugees are prioritized in the distribution of vaccine, then they're seen as competitors, and if they're not, they can be seen as a threat. There's been different examples. I mean, probably Giovanni and Anne have a specific one as well.
Giovanni or Anne, did you want to jump in?
Yes. Okay. I filtered out a few rumors from refugees related to vaccines here that I'll read out in direct speech, how we got them. So firstly, it says COVID-19 vaccines can make women barren, infertile, and we are the targets. Money meant for refugee monthly stipends have been reduced to help in search for coronavirus medicines and vaccines. Then only nationals will be vaccinated, not refugees. The vaccine is made to kill Africans since Corona failed to finish them. A post on WhatsApp says COVID-19 killed the former Burundian president and important people in DRC. And that is the reason why our monthly cash stipend was reduced, because the money is being used to look for vaccine and medicine. The vaccine is a trick to kill all refugees after 5 years. Then usage of vaccines to kill us poor Africans, especially us who are displaced. And then someone asked about a rumor collection initiative, I think. So I just wanted to say that my presentation was on the rumor bulletin, which in Uganda is an interagency initiative that broadly involves collecting and analyzing data on rumors and misinformation about COVID-19. So then I went ahead and shared a link in the chat box on how you can access this dashboard and look at the rumors on your own anytime you feel you should. So this is updated on a bi-weekly basis, so you can look at the most recent rumors once you log in. Thank you.
Thanks, Anne. Giovanni, did you want to jump in there?
Yep. Well, I think it is the same that Anne was told. Maybe some rumors that here in Colombia has more impact in the migrants than in host community is that, for example, as I said, injecting the blood of Venezuelans can cure the COVID-19, or rumors that say that if you take the vaccine, you're gonna turn into homosexuals. Those are rumors that are very, very attached to the situation of the Venezuelan migrants in the country. So that's why they are very, very dangerous. Also, there is right now like a rumor that that don't take for example, don't take the Sinovac or the Sputnik vaccine because they are going to turn you into they have a chip and they are going to turn you into communists, something like stuff like that. So those are like a really, and for example, Sinovac is the vaccine that the country is applying the more because of the COVAX and so on. So it's very, 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 very dangerous. Taking into account that Venezuelans, LGBTI Venezuelan peoples are like the lack of access. They have like a good information, the lack of access to good information, and the possibility to know the truth, to compare one information with another.
Thanks so much, Giovanni. From what what it stresses to me, I think the answers particularly is that a lot of the rumors and are very context specific, or maybe population specific, or specific groups have different rumors. And I think it really stresses the need and the importance of trying to listen to each community, not just the community on whole, but all the different groups within the community, to understand the different rumors and that's going on. Again, if anyone else does have something to share, please raise your hand or put your question in the chat box. I'll move over to the next question that we had. I think Anne has addressed this a little bit, given that I think the example she shared was so much interagency, but how to join efforts and include all agencies in rumor tracking and management of misinformation. Just wondering if any of the panelists or any participants have thoughts or ideas about this question. Genevieve's put her camera on, so.
It was just very quickly. So we have been doing this both in Cox's Bazar and in Afghanistan, and again with Internews and with other partners, doing community listening research, turning it into a little newsletter and sharing it every month. I think it is. It might even be every 2 weeks. So I mean, similar to what Anne was and others have talked about. But because that's, it's the sort of, it's shared through the RCCE mechanisms and then through the AAP in Afghanistan. So it means that all of your actors are already involved. So I guess the point is to find out what the networks are that are already there, and then use those and see who else you can invite in, basically. But I think it's use the existing networks and mechanisms and build on those rather than trying to start separate ones.
Thanks, Genevieve. That's a really, really relevant point. Does anyone, Giovanni, please?
Yeah, I think in our country specifically, we still don't know the impact of the misinformation of fake news. I mean, we are not aware of how it can affect vulnerable people, because we think social media is just posting memes and videos and selfies. But for example, the beginning of the declared pandemic in the country, about 1 year ago, there was a rumor that some institution, for example, I don't know how to, some institutions were giving cash for Venezuelans, and Venezuelan people went to the building, and it was fake. It was fake news. It was not true. So we are not really aware. I mean, the organizations, the government, the social, the people is not aware of the impact of fake news and misinformation in the vulnerable people. So I think the first step is raise awareness about it.
Thanks, Giovanni. It's a really great point. I appreciate it. Does anyone else want to jump in here? I'm sure there are lots of participants working on the ground that have experience on interagency collaboration. If anyone wants to share.
Maybe one last from me quickly.
Sure, Julie.
Thank you, Katherine. I was in South Sudan at the beginning, a year ago, let's say, when the efforts towards COVID started. And surprisingly, rumor tracking became the thing to do. So many agencies started doing listening activities and rumor tracking and trying to develop on parallel their systems. So that's a challenging part. When we want to do collaborative and activities, the challenging part is to agree on the system. Do we use the same one? Do we use the same tools? I know Anne in Uganda, they use Kobo tool form. They probably use all the same form for between the agency interagency group, which is great. But that's a challenge when everybody has their ideas. It's coming from HQ. It's a bit, sometimes it's top down. Sometimes some colleagues have not done it before. I really appreciate the effort in Uganda, because it was really linked to have local organizations leading the listening, and also finding the best intuitive way of doing it. So I think this is definitely a great lesson, great learning from this 1 year crisis, and that yeah, let's look first at what's being done, and let's work with what's happening, instead of trying to obey frameworks from the top. Over to you, Katherine.
Thanks, Julie. I think I mean, it also goes with what Genevieve was saying, right? And I think it's a really great point, and it's the need to understand what's happening on the ground, rather than setting up parallel or top-down duplicative systems to see what's on the ground, and invest and support where needed. I'm going to jump over to the next question. I don't see any hands or any requests to share information, so we'll jump over to the next question. The question was, what communication strategies are you aware of that can help stop rumours and misinformation before they spread and take root? Genevieve is ready. So I'll mute myself.
Just pop the camera on. Another form of putting my hand up. So again, media. And it's one of the things that I know us and Internews and a number of other organizations are doing, is trying to engage with media as partners, and rather than seeing them as this sort of one-way reporting press briefings, but really get conversations going, and using media as an opportunity to get conversations going and to build understanding. So how do you stop a rumor? If somebody understands and believes in the facts around how the body works, around how infectious diseases are transmitted, about how vaccinations work, and if they trust that information, they can hear misinformation, but it's not going to take hold. They're not going to start believing it. They're not going to pass it on. And so it's really thinking about both how do you build the sort of understanding around the health and the health issues, as well as then when rumours do start, which are the ones that you might choose to try and counter, but countering it in a way that is not sensationalising it, is not leading with the rumour itself, and doing this through lots of different formats. So you can do it through drama with characters having discussions. You can do it through interview and TV, like TV discussions, radio discussions. You can do it through online Q&As. There's all sorts of different ways, things like the Science in 5 on WHO. It's really the get creative, but also think beyond the message. Think about, what does somebody need in order to know something, like in the UK where we have hands, face, space, like what does that mean? How does somebody follow it? In one country, somebody might say catch a cough. What does that mean? So really building all of that understanding now, alongside then talking about the sort of vaccine specific, having the vaccine specific conversations and the discussions and so on.
Thanks so much, Genevieve. Does anyone else want to jump in on this?
Yeah, maybe quickly. One thing also we learned is giving facts is not sufficient. Just to complete what Genevieve said, like coming up, there's also, and in the media world, fact checking, fake news, battling with fake news, and we say, fact matters, and fact is what will bring clarity and stop rumors. What we realized is that it's not enough, and as Genevieve said, we have to address the fears and the context and the history, the trauma behind, and also importantly, being humble and respectful and listen. If people believe a specific rumor, we need to spend time to listen to their views, and in a respectful way, and engage in dialogue, and not just saying, those who believe this are are stupid or uneducated, because it's not, it's definitely not going to solve the issue. No, like thinking about vaccines, those who are against the vaccines or afraid of it have their reasons. So if we just say people who don't want to be vaccinated are anti-vaxxers, are stupid and dangerous, it's not how they will change their mind. They will feel put aside, and they will not be part of the dialogue. So, yep.
Thanks, Julie. So I think that's a really great point. Humble and being respectful, and I think we all been in situations, right, where we don't agree with someone. If someone insults us, I think we automatically stop listening. I wonder here also whether it's worthwhile just sort of flagging again. I think it came up in all of the presentations, but the engaging with the community and understanding the trusted sources of information, and working with the community and those that are trusted within the community to get information and the facts as well, I think is important. I'm going to jump on to the next question unless anyone wants to jump in again. Really interesting question here. How can we make sure that people in rural areas who sometimes don't have access to information get vaccinated for COVID-19? And if there's anyone that wants to, Genevieve.
I'm happy to respond, but other people, please do jump in. So again, and it speaks completely to the community listening point, is so it's always asking is like, so why aren't people in rural access? Is it why don't they have access to information, or do they not have access to information? So people will be getting information from somewhere. They might not have access to a mobile phone or radio or TV or digital, but people will be getting access to information one way or another. And so it's finding out what are the barriers, what are the challenges, again, listening to people, understanding what might be preventing them from engaging with information, as well as then engaging with, for example, vaccination services, and then helping to overcome that, because it may be about an attitude and belief, it may be about a motivation, it may be a very practical issue of there just isn't radio connectivity in a very rural area, or there isn't digital access in a very rural area, or somebody, maybe it's depending on disparities in, say, gender or age or anything else that might lead to somebody having less access than others. And so certain people might not have access to up-to-date information, or information that they can choose. So social media, you can choose. And language, yes, Julie, exactly. But you know, if it's digital, you can choose what you look for. If it's a program that you're listening to on the radio, there's or TV, then there's options, but it's a bit less choice. So it's, I think, just understanding what the issues are, and then helping people and working with the community to then find solutions that work for them.
Wonderful, thanks so much. Yeah,
Can
Giovanni,
I come in
please.
here?
Oh.
No, it's okay.
Yeah, Noreen, I'll let Giovanni come in, and then Noreen after, please.
Yeah, sure.
Me first? Okay, so I think that there is like two issues here. Is that, for example, in Colombia, the access to rural areas are very, 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 very difficult. So most of the people live in areas where even you can access by motorcycle or car. So it's really difficult to take there the vaccines, or they go to the nearest town to get vaccinated, because they don't have as well the economical resources to go there. And then the vaccination process is a responsibility of the government. So I think the only way we can make sure that people in the rural areas get vaccinated is it's like press the governments, the local governments, to ensure these people can get these the vaccine through help to go there, or even the making like small tours by these areas that are not of easy access for cars or models. So this is like one way to do it.
Thank you so much, Giovanni. Really great point. Noreen, did you want to jump in?
I just wanted to say, and already Genevieve flagged that, and I want to take that forward because that's very important. It's just, we have to stop assuming what people are thinking, and we have to stop doing things on the basis of the mostly assumptions. Sometimes people need more information. Sometimes people need different kinds of information. So that is something that has come up from many countries. Just yesterday, there was some data presented from Pakistan and neighboring countries. And the idea was like, you know, they have maybe one of the best communication or the radio and TV programs, and they have engaged with all the religious people and everything because of Ramadan and Eid coming up. But then we looked at the observational study that was done, 85% people were not wearing masks. So I just want to say that sometimes it's what we do, whatever we do, is just on the basis of some assumptions. So we really need to think about that. Bombarding them with information is not going to change anything. And that's where we need to work on instead of everything. So I would really, I have noted down as some of the takeaways for us as well. Over.
Thanks so much, Noreen. All right, I'm going to jump on to the next question. Again, I will encourage anyone listening to write questions, put their hands up, share their experiences. So we have how to address mistrust and superstition among persons of concern as regards vaccine. And I think a lot of the presenters have really addressed this in their presentations. Listening is, as we just also heard from Noreen, really it's about listening to the community and working with the community. Does anyone else want to share anything in addition to what they've already shared, or do we think we've happily looked at this and let's move on to the next one? No cameras are jumping on, so that means I am going to switch over to the next question, also in cautious of time. And I already know Anne wants to jump in immediately on this question, but what is the role of community engagement in risk communication? And I'm going to hand over straight to Anne. Thanks.
Wow. Thank you. So the role of community engagement in risk communication, from the AAP perspective, I believe this will even handle the previous question and the one that talked about access of vaccines by those in rural areas. So communities must be at the center of any public health intervention, especially in emergencies. There is need to directly involve those affected in understanding the risks they face. Now, as humanitarian organizations, we ideally are supposed to design and implement programs in a way that takes into account the views of our clients, of persons of concern. And this way, we need to design programs that promote systematically listening to their perspectives and using their feedback to make decisions, and in turn communicate and explain to the clients how their feedback has informed our action. Community engagement in risk communication promotes listening to the people and ensuring equitable access to information and services. For example, information on an actual uptake of vaccines in this case, and the use or taking heed of the SOPs from the, say, Ministry of Health. Now, from a rights perspective, everyone has a right to know about risks to their health and well-being. So by involving community, we ensure that culturally appropriate information can help make informed decisions to reduce health risks. And I think we all know that action taken by individuals, by families, by communities, or even society affected are key to controlling the public health threat or a problem. So therefore, there is need to engage the community to curb the existing problem. this will ensure that they adhere to the SOPs, and this way we shall promote behavior of vaccine uptake by the community, by family, community, and the entire society. So then all in all, there is need to design strategies that reach out to the most needy by first conducting assessments and finding their needs, involving them on the different strategies on how to reach them, the most needy deep in the community. That way, if we find their issues and design strategies with them, then we shall reach out to them and involve them fully in the entire, in our entire program. And that way, it's a way of being accountable to our clients or affected communities and stakeholders. Thank you, and back to you.
Thanks so much.
Could I
Thanks
add,
so much, Anne. Please.
Could I add something just to add on what Anne said, which is like so important, and it's really this thing of you can't do risk communication without community engagement. It's not possible. You don't know what people perceive as a risk. You don't know what their priorities are in terms of a risk, and I mean it's been vital to us for this past year. I mean, we always think about risk communication and community engagement together, but for example, over the last year, through kind of community engagement and research, one of the things that came up for our programming in Somalia was that people would cover a cough if they were indoors, but if they were outdoors, they wouldn't. And because it was seen as less risky because you're kind of out, so it's going out in the open and it's going away. And the idea of covering a cough or a sneeze was seen as really risky because you were seen as holding an illness or disease inside of you. We wouldn't know that without community engagement. And when you know that, you then start to think about, okay, and talking with communities about, okay, so why is that risk perception there in some circumstances and not others, and then okay, how do we do communication to help people believe that actually in both situations you need to cover a cough, for example. Thank you.
Okay, so in that case, community engagement in risk communication helps us to be more effective by driving us towards achieving the results and the change that the clients want to see. It helps us in meeting clients' priority, needs, and expectations, while of course considering the context and situation they are living in, just as explained before. Thank you.
Thanks so much, Anne. Thanks, Genevieve. If I can just, add on this point as well, I think it's the presentations, right? Listening to Anne, some of the rumours that she mentioned from Uganda, then Giovanni, and just how different the rumours were in the LGBTI community, for example, plus community, for example, in Colombia, and then some of the rumours that Genevieve just shared, it's so different. And it just, I think, really strikes home how important it is to have that community engagement. Without it, we just don't necessarily, we're acting blind, right? So I think it is really, really important. And thank you so much for sharing that. I think we have one last question, and I'm still encouraging people to drop questions. We have a little bit more time in the chat box, or to ask questions or put their hand up and share information. One of the questions we had was, where can I get trainers? I'm not sure if it was meant to be trainings or trainers on COVID-19 vaccine communication. I'm going to go straight to Noreen, because I know that there is the demand creation package maybe, but Noreen, do you have any more information on this question?
Thank you, Katherine. Yes. So this was an important question. I did look at it, and I took note of this as well, because that's what many countries are asking, because as they are going into their, vaccine deployment plans, and some are actually waiting for the vaccines and preparing for it, and they're learning from other countries that have been, really dealing with different rumors. So we do have a package, and first of all, that package has really good and practical training package for health workers as well. So there was a learning from data that health workers, also, among health workers, there was a very high level of vaccine hesitancy as well. So you can very well imagine, because in many communities, they are the influencers. So it was very important to really, first of all, prioritize them and work with them. For COVID-19 vaccine communication, there is a package, very practical tools There is a tool also that through which you can quickly get a rapid qualitative assessment. You don't have to have a lot of resources on for that and all that. Everything is done for you. Key questions are there. So countries are actually following and using that package. We can share that package, Katherine, and also all the other list of resources that we have from different countries. And I can also share one or two examples of what the demand creation plan looks like from different countries. So that can also be something that people can get benefit from. And then if you need any further support, we are always there beyond this deep dive. The idea was to really let you know that we are all here to help you, and we don't want to just be sitting at the headquarters. We want to work more operationally on ground. Over. I'll be sharing the package.
Great, thanks so much, Noreen. And I mean, we plan to share with everyone the recording of this webinar, a deep dive, and we can also share some additional links to training tools and resources that we have after the webinar. So also for participants, if you are aware or you've developed trainings, please do share. We can also share. Now that's the last question that we have at the moment, unless anyone wants to jump in right now. I am going to hand over to Noreen for a recap. I will stop sharing my screen and mute myself and hand over to Noreen. Thanks very much.
Thank you so much. Okay, I'll be very quick. Let me share my screen. Just let me know if you can see it.
I can, yep.
So some of the issues throughout this discussion and important issues, I mean, some of them are, I really appreciate the presentations because such insight and direct information from the ground, and we have learned a lot throughout the discussion. There will be so many more, but when we prioritize, number one, there is lack of accurate information. We have learned it in many countries, and especially, when we learned from the presenters. So we need to learn the impact. What is the impact of misinformation? That's very, very important. What are people's behaviors in responding to the misinformation? And to be very honest, it is really not about any other smaller countries. I'm also talking about US. That is where we are right now, and there is a lot of misinformation floating, and people, my friends, even when family ask me questions that to me are very similar to what everybody was reporting today. There is a lot of stigma. That is something which is ongoing. It's an ongoing critical area, especially among the migrants, refugees, and other populations that we are focusing on. They do not feel safe, definitely. And it's not just Venezuela, it's many other countries that are reporting that. There are a lot of rumors about migrants, and we need to set up, and thanks Anne for bringing that up, because the AAP, accountability to affected population, means there has to be some community feedback mechanism. There should be some way that community knows that he or she can go or call to express the concern, ask questions. That is where we learn. Then there is lack of evidence, and we all know that. We need to build our evidence base more and on regular basis. There is lack of trust among the communities, sometimes on the government, sometimes on the other health system, sometimes on the decision makers, etc. We need to strengthen our advocacy, because if we want to have a more equity, we need to advocate with those people who are taking or making these decisions. Then access issue, we all know that it is very much there. Many countries are facing a lot of challenges, including countries like Syria, Iraq, and so many others like those. There is issue of gender. In Pakistan data, as I earlier mentioned yesterday, there was an issue of gender because there were more men getting access to vaccines rather than women. So that is one of the issues highlighted. Lack of on-ground collaboration among partners is still a challenge for us. We are still struggling with that. And I think that with these kind of interventions, joint and collaborative effort, I wish that we translate this kind of collaboration on ground as well. We need to have a mechanism where there is collective capacity building. UNICEF doesn't have to come up with their own, resources and the modules and everything, and WHO doing it separately. We're doing something together with WHO, but I would like to also open up here that We are willing to do that with all the partners here and also share the knowledge on ground as well. So these are some of the key takeaways. I've just tried to kind of, given the time and the ongoing discussion, I just want to say that 3 areas that are very important. Number 1 is advocacy. It's very important. This is not just my learning from this webinar, but also beyond. There has to be, more media engagement. I cannot agree with this more. We all know that we are getting most of our information from that, and that is where we are getting mixed information. We have to advocate for media engagement. We are not just talking about 1 or 2 meetings and sending them the media flyers or something, no, engaging with them, letting them understand, partnering with them. We have to monitor through media as well. Not just, sitting and looking at the social media, but also media to be engaged to monitor what's happening there. So then more emphasis on rumor tracking and misinformation. I cannot emphasize this more. It is still amplifying in spite of the fact that we are doing a lot of effort. But then equitable distribution of vaccine is still an issue, and our subgroup is working on an advocacy brief because of that. Accurate, timely information is very important. I still know I will not take the names of countries that are supplying certain kind of vaccines, and we are told not to talk to people about what kind of vaccine they are going to get. Then strong coordination mechanisms among partners on ground. I'm not talking about global level now, I'm talking about the actual field level. Strong coordination, resource mobilization is very important, but it has to be done jointly. It's not just resource mobilization for consultants and all, but how do we invest in communities, joint efforts. Then the middle part of this is very important: capacity, community engagement, media. They have to go hand in hand together. Community engagement, media is a community. Community is not just people sitting under the tree in a village. So we need to prioritize the populations that we're talking about. Tailored, participatory, somebody said that, very important. Listen to people, doable actions, learn from them. Media to do more, but what do we mean? Systematic engagement. It's not that media doesn't want to partner with us. We need to be really be a little bit more proactive. More than just messaging, I gave you an example of Pakistan that was just presented to us yesterday. Be creative, role models. They really work in the communities, and also continue working with community influencers. For evidence, it's very important, and we have realized it earlier as well as the subgroup, that is where we need to pay more attention and work more with the countries. Rumors tracking, monitoring systems are put in place in some regions, as I just said, but we need to take it down to the country level. Social media mapping is very important, but the relevant approaches is important. One size does not fit all. Research and research. We need to continue doing that. We need to learn about the barriers also. Their behaviors are there, but what are the barriers? We need to understand why people are doing what they do, and then include local communities in monitoring. And that's very important for the sustainability. So for the subgroup, Katherine, just quickly, I was just looking at, how do we make sure that we prioritize for us after this? We already have a draft of advocacy brief, which is very important. We need to promote the equity and gender in that and promote people-centered approach. Tools for the research, we already have some tools. We need to make sure that, we disseminate, we make sure that countries know about it and countries use it, and we help them using it. Then document some practices, and it's very important. Learning from each other, like we learned so much from the presenters today. And then organize country interactions. We can think about that as well as a subgroup. And then capacity building of CSOs, community-based organizations. Everything needs to be localized. So that's it from my side. Over to you, Katherine.
Thank you so much, Noreen. That was a absolutely outstanding recap with the very short amount of time that you had. So thank you for that. And I guess I will open one last time in case any participants have any further questions or comments, anything they would like to share. Any of the panelists would like to share anything. Otherwise, I would say thank you very much to Julie from Internews, Genevieve from BBC Media Action, Giovanni and Anne from ULearn, and say goodbye. Thank you.
Bye. Thank you so much.
Thank you very much.
Katherine and
Bye.
everybody.